I'd like to begin my comments and questions with acknowledging the gentleman and the senator from Beaver County, Senator Elder-Vogel, for his leadership, and acknowledge his ability to work with interest groups that have inverse interests, and a very forward-looking bill, an innovative bill. I've got to give him a particular acknowledgement for being able to get this bill across the finish line in the Senate, as the minority chairman mentioned, in a 49-0 fashion. I'd also like to acknowledge the leadership of the gentlelady from Bucks for her bold leadership and commitment to making our healthcare system centered on patients and physicians, and having reasonable, responsible legislation crafted. So I'd like to begin with the repetitive characterization of the insurance mandate, or the coverage mandate. And I think it's important because there are a lot of healthcare services, treatment plans, prescriptions that are not covered by health insurance. Occasionally, the legislature will intervene in that free market relationship and marketplace, and we will pass legislation that requires coverage, an insurance mandate, as we would like to call it up here, a coverage mandate requiring that those healthcare services, procedures, drugs be covered. In spite of the characterization, or maybe not in spite of it, but just to make sure that it is well documented that that's not what we're talking about today. We are not requiring that additional services be covered or new services be covered. All of the services and procedures that are covered in an insurance policy are going to be covered under this bill, no more, no less. I think you were very clear in explaining that, but I think the context of in the legislature where insurance mandate is perceived to be something, and I believe this bill is not that it isn't a mandate and not that it doesn't deal with insurance, but in the traditional legislative context, I think that's worth noting. And so to say that every service that is covered in office in a healthcare policy will now be covered if it was done via telemedicine does seem like, as you mentioned, a wide swab or a blank check. But to be fair, that's not the only control of whether or not you would pay for a broken leg that was done via telemedicine. There are other controls that would ultimately determine whether or not you would cover it. What this bill says, though, is it just cannot be denied purely for the fact that it was done via telemedicine. So that broken leg hypothetical, there's other controls in place, like how much the provider will be paid for fixing a broken leg via telemedicine. That physician must be in network. So we're not talking about physicians that aren't in your network that would be fixing that broken leg. It must be a covered service, which in this hypothetical broken leg was probably be covered, but not all services are covered. This doesn't say that more services will be covered, so there is a limitation on what service can be provided. Those controls are already in place. And there's also two other limitations on whether or not a telemedicine appointment or service would be covered, and that is that it must be consistent with the insurer's medical policy, and it must be medically appropriate. Now, my first question for you, Mr. Marshall, is in your written testimony, you seem to have some confusion about those two limitations, that in order for a service to be covered, it must be consistent with the insurer's medical policy, and it must be medically appropriate. Your two-part confusion, though, could you elaborate on why you were confused about those two phrases? Because they do seem rather ambiguous maybe to the common person, but in the physician-insurer context, those are not subjective phrases. They actually have very objective definitions, correct?
I wouldn't necessarily agree with that. I don't think that that's actually some of the reason I'm confused. For instance, medically appropriate, as determined by who? And going into, medical policies. If an insurer's medical policy is that it is not yet convinced that a particular specialty is appropriate to telemedicine, that it hasn't proven to be effective in an overall sense. Is that, can the insurer then say, our medical policies don't extend coverage of telemedicine for this particular service?
Well,
That's a question.
So medically necessary or medically appropriate, as the language says, sounds very general to me as a former car salesman and a layman. But if I look at an insurance policy, medically necessary or medical necessity has a very lengthy definition in some insurance policies. In fact, I'm looking at one. It must be clinically appropriate. So that broken leg via telemedicine, I don't think would be clinically appropriate, and therefore would not be paid, correct? Because that would fall outside the bounds of medically appropriate, correct?
Well, for one, I think, and this is one of the questions, this is why it's good to have this discussion. Not sure that everybody would say that medically appropriate is one and the same as medical necessity. You're reading a definition of medical necessity. I think that can be different than medically appropriate, because what we're, and that's why it's good to have this discussion. What we're trying to figure out is what level of control, what level of involvement. I'm not even talking about control, because these are network providers where we negotiate contracts with.
Okay, but I have a few other questions, and I know the chairman, he likes to keep me short and sweet, which I don't think I'm going to meet today. But medically necessary versus medically appropriate seems like a grammatical error, a change of word, which words matter. And if that's your recommendation as well, it should not be medically appropriate. Medically necessary does have contractual policy implications, which are lengthy, and I'm not going to read them all. I'm happy to read it. But it is very well defined what medically necessary, which includes clinically appropriate, means. And not to mention, consistent with the insurance medical policy, is defined in your recommendation. You made a recommendation of an alternative to this bill, the Rhode Island language, and you sent us some draft language. And just so it's clear, your recommended language says, so long as such health care services are medically appropriate to be provided through telemedicine services, subject to the terms and conditions of the agreement between the insurer and the network provider. I don't see much difference between that recommended language and your suggestion and the language in the bill, but if it needs cleaned up, I think I would be willing to offer that. I would like to talk about another concern that you had in the prior authorization potential requirement, or the hypothetical that the bill does not address a prior authorization requirement. I think your testimony said that a prior authorization could be interpreted as being appropriate in this language. Are you suggesting that there are your members or anyone from the insurance industry, are you recommending that there be a prior authorization requirement? Are you in support of a prior authorization requirement? And do you read the bill as allowing a prior authorization requirement?
I'm not recommending a blanket prior authorization requirement any more than we would recommend blanket coverage, which is one of the problems here. But there may be, and different insurers are going to vary on it. And you may have different requirements within your own network because you have a wide variety of providers in that network. But you may, as telemedicine evolves, say, you know what, we're still getting comfortable with this. We realize it increases utilization. We want prior authorization to make sure that it's the right utilization. Can you require prior authorization of a telemedicine service if you don't also do it for in-person? That's
correct.
A question.
Well, so my question then, practically speaking now, due to the inconsistencies, the lack of uniformity as it relates to telemedicine appointments, how would you recommend to my constituents or the public that they find out whether or not they are currently covered? Because I've heard horror stories of people that get stuck in traffic from Bedford to Pittsburgh because they weren't covered and had to hop over the guardrail on their way to take care of themselves. Those are realistic problems. So realistically, how should someone find out whether or not they have coverage?
Each insurer, I think now does, and we don't have, for better or worse, we don't have that many insurers in Pennsylvania. And we certainly don't have that many in any particular region, maybe 3 or 4 at most. But each insurer does publish now, and if it's unclear, then I guess we all ought to take steps to make sure that it's clear.
It is unclear. So how would somebody get clarity, a patient get clarity of whether or not, while the marketplace figures out how to work this, what is your recommendation for those people to find out if they have coverage?
Our recommendation is that each insurer clarify with each policyholder.
To me, that's a fact. I understand. That's what I would recommend to my constituents, which in many ways is a de facto prior authorization. You've got to go find out whether or not you have to drive from Bedford to Pittsburgh to see the physician that is treating people in Bedford for the same services, but you may or may not be covered.
No, I'm sorry, maybe we're talking.
They need to find out whether or not they have coverage, and I'm just saying.
You know what, Representative, you're exactly right. And you know what, and if somebody says here, every insurance company shall notify on an annual basis, whatever it is, at policy renewal, should put forth, you can have it reviewed by the insurance department, put forth clarification on just what telemedicine services it covers and for which providers, okay. That's not prior authorization in the sense that
I know what
which is
I'm saying.
Case by case.
I'm saying it is implicitly serving as a prior authorization because people do not know. And I'll go back to another practical problem. Your testimony says that the telemedicine's impediment so far isn't so much insurance as patients being comfortable with it. Your general, I'd say rather convenient assessment is counter to what I've heard from patients and physicians. In fact, one highly skilled specialist that I met with on this issue who treats patients doesn't treat patients that are uncomfortable with telemedicine. He's treating patients that not only are comfortable with it, but want it. But the number one impediment that he told me between him and his patients having access to him is insurance. And so I can appreciate that your characterization is that it's about utilization, but we're not forcing anybody to utilize it. We're just allowing the people who want to utilize it to be able to.
If I could just, what I meant in the patients not taking it up, you're right, the patients who take it up are fine. But what a number of our members have found where they offer telemedicine coverage, for instance, for primary care, is that such a small number of patients utilize it, get their care through that it's actually, it's not cost effective for the carrier to continue, because we have to set up infrastructure too. It doesn't come at no cost to us. It's actually for that particular carrier has been shown, and others.
But that is a distraction.
Excuse me.
But that is a distraction, and with limited time, that is a distraction from what we're trying to do. If we were trying to force people to use telemedicine, but that's not the language of the bill, and I just think it's a distraction from what we're trying to do. Just want to say it's hard to ask questions on the bill's language to those testifiers that support the bill as drafted and recommend passing it as drafted. So my questions have been and will be focused on the insurance community, and it's because you have legitimate concerns. You have legitimate concerns that I think many of us want to address and try to find a solution that works for everyone, whether or not that's practical. I just wanted to state that it's not to be antagonistic. It's to try to reach the best bill and to hear your side and see if there's a legislative solution. And so, once again, as I selfishly plug my senator's leadership, Senator Vogel on this prime sponsoring this bill, significant health care reform. Senator Vogel wasn't an innovator, as it's been said. This bill is not a new concept. 38 states have some type of uniformity language. States like Texas, Georgia, Mississippi, also states like California, New York, and Vermont. Needless to say, this is not a conservative issue. It's not a conservative healthcare issue. It's not a liberal healthcare issue. In my opinion, it's a patient-centered healthcare issue. And those states, I think, reflect how a lot of people feel. Republicans, Democrats, there's a lot of frustration. And in a state like Pennsylvania that has the geographic diversity that we have, there's a lot of inconsistencies around the state. So I commend the chairman. Once again, I didn't in my opening comments, but commend the chairman for his leadership. And I think it was appropriately described as that the healthcare provider and health insurer relationship is terribly complex, exceedingly complex and complicated. Yet this bill is being criticized for being too broad, for providing too much flexibility, for allowing the health insurers and the providers to navigate that tremendously complex relationship. One of the solutions was that before we solve these issues of these ambiguities or these broadness issues on price, on services, further defining providers, further providing specifics on those issues, it was recommended that we do those things before we pass it rather than after. But my concern there is that means we're legislatively addressing those issues, that we are further handcuffing the complex relationship. And those issues, while they're not legislatively addressed, they are addressed. They're addressed in contractual relationships, contractual obligations. They're addressed in the private sector that we heard is doing this already in some instances and successfully. So what I'm seeing is you have the solution, it just needs to be broadly applied, and it's not. And that's the problem I think we're trying to solve. It was the question was, can you reach these contractual obligations or these contractual relationships and these terms on these ambiguous issues within 90 days? Well, you've already reached, you bragged in a good way of how you've already reached those terms, and this is working in some instances. So I don't think that the legislation is asking you to come up with all the terms from the ground up. The relationship exists. These terms, these obligations, this ambiguity that will be fixed in the private sector rather than legislatively will get fixed. And I don't think that us addressing, let's just say, the price issue by doing what other states have done and handcuffing you with parity legislation is the best solution. But I almost feel like that's what's being advocated today from the insurance community, implicitly saying, let's address these things now. Let's clear up all the ambiguities. I mean, you're not obviously advocating for parity payment because that would provide you the predictability, but that would further limit you to work out those agreements with the providers, correct?
Okay, first shot. The questions that we raised with respect to the ambiguities we find in Section 6A aren't things that we think we don't know if we can do them. As I mentioned, I don't know if we can say, hey, we're going to have prior authorization for telemedicine that we might not have if it were delivered in person. That's a question. Is that what's intended in the bill, or do we still get to have that, don't we? That's a question. I don't know that we can say, here, we'll have different payment levels for different providers within our network when they're doing telemedicine because we think some do it at a higher quality level than others. I don't know if we can say not all providers, and Kim mentioned here, we're dealing here with the mega provider, Representative Court's reference to, the gold standard. But there are a lot of other providers in our network, and this would extend equally to them. So those are sort of some fundamental questions about how far does this shall reimburse any participating provider go. Those are things that we ought to resolve now, because otherwise we're going to come back and we're going to say we read it this way and some provider is going to say we read it that way. The one thing I would note, going to what you started out with, and it's been a frustration here, we're all about saving money. We're all about holding down rates for our policyholders. That's, rightly or wrongly, yes, we care a great deal about quality, we care a great deal about access, but we're also under very strict controls to hold down cost. If we thought that this was going to reduce insurance premiums, we'd be the ones advocating it. That's where if you take the dialogue out, that our concern is that when you remove the dialogue, and that's the way we read Section 6A, when you remove the dialogue that goes on between the insurer and the network provider, our concern is that by removing that dialogue, you're taking away our ability to have any involvement in ensuring that it's going to be quality, access, and cost effective.
What we're taking away in this bill, as I read it, is that what is not negotiable is covering a telemedicine appointment. It's not, yes, that comes off the bargaining table. That can no longer be negotiated. That power has been legislatively determined.
Correct.
Yet the price, yet the rest of your contractual relationship as it relates to in-office visits, as to who's in your network. Like I said, medically necessary does also deal with frequency. There's this, listen, I don't think any of us want to raise the cost of health care. And when we talk about overutilization, I mean, that's great that people are getting more care, which I think is wonderful, but we're all concerned about cost. So when the insurance community says we're worried about costs going up, yet you are limited, the providers are limited by what's medically necessary, also addresses frequency. So every time I check my electronic health record on my phone, they can't reimburse for that because it's laid out what is medically necessary and has to be consistent with their contractual relationships. And so I guess my overall concern, maybe for the next few days as we move forward and in this session, rather than maybe highlighting the concerns, if we could provide some solutions to these ambiguities, this broadness, because I ultimately think if we were to put an amendment to take away the payment issue, the rate issue, how much they're paid, and put parity language in place, I think the insurance community would oppose that. And so I guess all I'm hearing is a lot of problems this morning, but not a whole lot of potential solutions, and whether or not a legislative solution is the best solution, because these issues won't evaporate. They will just move to a different forum in a conference room at the bargaining table, hammering out the details. But what will not be leveraged and cannot be negotiated is coverage.